EUFOREA launched its first global chronic rhinosinusitis with nasal polyps, or CRSwNP Awareness Day, in 2022. And in so doing, it set out on a mission to raise awareness of this debilitating and widely underestimated disease. Now, this campaign has multiple aims: to educate patients and healthcare providers about CRSwNP and its comorbidities, but also to highlight the profound disruption that this disease plays on both the physical and the mental health of its sufferers. The 2023 Global CRSwNP Awareness Day theme is Let's Talk CRS. And this campaign aims to improve communication between patients and their healthcare providers in an effort to achieve optimal outcomes for all patients. So, let's talk CRS. Hello, I'm Dr. David Bull, and welcome to the second annual Global Chronic Rhinosinusitis with Nasal Polyps Awareness Day, being held here in Brussels in Belgium. Chronic rhinosinusitis with nasal polyps, or CRSwNP, is a chronic inflammatory condition of the nose and paranasal sinuses, affecting about 1 to 4% of the general population and about 30% of patients with chronic rhinosinusitis. It's caused by type 2 inflammation, and that means that patients often present with comorbidities. They include asthma, atopic dermatitis, and allergies. Symptoms of CRSwNP are both physical, they're also psychological, and they can be very distressing indeed. Symptoms include nasal obstruction, smell dysfunction with anosmia, continuous nasal discharge, and facial pain, also poor sleep quality, hearing impairment, and depression, all of which profoundly impact patients' quality of life. However, many patients needlessly suffer in silence, often for years, without a proper diagnosis or referral to a specialist for appropriate treatment. So the question is, why is this? And how do we get all stakeholders, and by that I mean physicians, patients, policymakers, to talk about CRSwNP and continue making strides for patients around the world with this debilitating disease? Well, to discuss this further, I'm delighted to introduce our panel of experts and patient advocates. First of all, Chabha Djouder, nasal polyposis patient ambassador from anosmi.org in France. Joining her is Natascha Siemes from EUFOREA's Patient Advisory Board based in Belgium. Alongside them, Daisy Waeyenbergh from EUFOREA's Patient Advisory Board, also from Belgium. Also on the panel today, Duncan Boak, Chief Executive and founder of Fifth Sense in the United Kingdom. Moving to our medical professionals now. First of all, Dr. Dermot, Honorary Fellow at the University of Edinburgh in Scotland. And last, but by no means least, Professor Wytske Fokkens, Chair of the EUFOREA CRS Expert Panel based in the Netherlands. A very warm welcome to all of you. Thank you very much indeed for being here. Right, if I may start at the beginning, let's start by highlighting the unmet needs of patients with CRS. Let's start with you, Wytske. Professor Fokkens, I should say, actually, to be accurate and correct. I mean, clearly, you've got decades of experience, as I know, of treating patients with CRSwNP, and I think you and I have talked about this a great deal, the way that treatment has evolved over the years, obviously moving from surgery, oral corticosteroids, that really was the standard treatment. And of course, then we had the advent of biologics, the monoclonal antibodies, which was really quite a game changer, I think. I think also we're now starting to see patient voices being introduced far more in clinical practice with the aim of improving patient care. Do you, and I suppose that the really important question here is, do you think that chronic rhinosinusitis with nasal polyps is now more widely recognized amongst the physician community and also amongst the patient community?
Well, thank you, David, for that question. It's really important. If we look at the half-full glass, yes, we're definitely doing better. More people recognize the disease, more people see the impact of the disease on the quality of life of patients, but also costs, for example. Biologics helped because it brought it to the payers as something that is expensive as a treatment. On the other hand, we still see on all levels of society from press to healthcare providers, politicians, even GPs, and some specialists not in the ENT field, insufficient knowledge of the disease. So there's still a lot to do, and for that reason, this day is extremely important.
I find that extraordinary, actually, that we're still in a position where the GPs, the primary care providers, don't know enough. That's a real problem.
Yes, that's absolutely a problem, and very difficult to change. Apparently, it's not sexy or not interesting, or people do not realize the impact. Most people don't die of chronic rhinosinusitis, but most people don't die of asthma now. And asthma is seen as a serious disease. So there's really something to do.
I should probably come to you, Dermot, really, as a GP, and allow you to counteract that. Is Wytske right?
She's largely right, but I think the big thing is the lack of awareness of the impact of chronic rhinosinusitis on people. You're probably aware there's not much ear, nose and throat teaching as an undergraduate or as a postgraduate in general practice training. So it's not an area which is prioritized, although it is a chronic disease. The other chronic diseases, particularly heart disease and COPD, osteoarthritis, diabetes, obesity, are all prioritized. And to some people, this is seen as a niche. I don't think that's the right thing, but that's the reality of the situation. So I think A, it's seen as a niche, and B, the basic knowledge isn't there.
Yeah. So just in terms of the patients that come and see you, do they have a level of understanding, do you think, now?
Most patients' level of understanding would be quite limited because it's not in the media, unless you know precisely where to go. The GP or the pharmacist who may be involved in their care knows little enough about it and can't really, because of their lack of knowledge, put the patient on the right pathway. And I think this is probably something many patients have experienced.
Would you agree with that, Wytske?
Yes, fully agree. Yeah. It's really an issue of still in many layers. It's treatment should be antibiotics. It's an itis, should be antibiotics. Pharmacist, oh, do you have a cold? It's not a cold. It's not an acute disease that needs to be treated with antibiotics. And even on that level, it's already going wrong.
I mean, certainly since I've been involved with all of you and talking about this subject, it seems to me that CRSwNP does have a little more awareness. It's now no longer perceived as sort of a side effect of conditions like asthma and atopic dermatitis. Do you think things are changing?
Yes, but too slow.
Yeah.
And anybody who can help to think how we can improve, and I really think we have to improve patient knowledge, empower patients, and in that way get more knowledge of the disease everywhere in the community.
I couldn't agree more. So we're doing better, but we're not doing well enough. So let me come to you, Dermot. I'm just looking at the figures here. I mean, EUFOREA spent a lot of time highlighting this burden of disease, this clinical burden that's unmet needs and so on. And EUFOREA then published its paper, Patients' Unmet Needs in Chronic Rhinosinusitis with Nasal Polyps Care. But when you talk to patients on the ground, this is all very well having an academic paper, but when you talk to patients on the ground, they say, well, actually, it takes ages to get any sort of referral from a primary care. Even if your primary care physician picks it up and says, right, you need a referral to a specialist, it's not happening. Why is that?
Well, I think that there are various elements in the delay. So if the person's primary pathology is asthma, they may not mention the upper airway. And people think of the upper airways purely as being allergic rhinitis, which is a different disease altogether to chronic rhinosinusitis, and may be treated with topical nasal steroids, and really not more, or more likely, as is the case certainly across most of Europe, second-generation antihistamines, not even topical nasal steroids, because it's allergic rhinitis. That's the link they're making. People come in with depression, but you can't identify the cause of the depression in their life, but it's because they have a physical illness that they haven't necessarily managed to tell you about. People come in with headaches, and it's often misdiagnosed as migraine. But I mean, management of migraine, although it's an extremely common disorder, is also not perfect in primary care. So it's mixing up all of these different things. And one of the big problems with primary care nowadays is that everything's guideline directed. And people think, okay, so it's probably related to asthma, so I'm going to go down that pathway. Or it's related to headache, so I'll go down that pathway. And they don't think that the patient may come with 2 or 3 different problems, and they're all interlinking, which is why it's really, really important to take an holistic approach to patient care and think about what's going on, and then putting it together, collecting the different pieces of the jigsaw from different parts of the puzzle, rather than just having one puzzle.
I mean, do you think things have changed? I mean, certainly when I trained, we were told that you basically take all that information in and you should adopt, as you say, a holistic approach. And if you are going down these structured pathways, if you don't think about CRSwNP, you won't diagnose it.
The structured pathways won't lead you to think about CRSwNP.
So that's a problem.
That's a problem.
Yeah. And has that changed?
I think it's getting worse. I think diseases are being put into silos. And you refer within those silos to the appropriate, might be the appropriate specialist. But because the specialists are so specialized, if it doesn't meet their area of specialty precisely, they'll say, well, you haven't got this, go back to your GP.
Yeah.
So the patient goes bouncing backwards and forwards between different specialists until eventually, through an act of God, they get to the right person, and their treatment is their condition is recognised and treated.
So it's really hit and miss. Actually, you need to find the right physician at the right time and get the right diagnosis. Wytske, you were nodding along. This isn't just a UK problem, clearly.
Definitely not, unfortunately. No, but although I think referral in some countries is easier, in some parts of Europe is easier than the UK.
Yeah.
So. And also the bouncing back to the GP, although officially that should be done. We, for example, have a lot of collaboration with the pulmonologists and the pediatricians to have direct contact, to try to get that same holistic approach, which is so important.
It is indeed. I don't want to go into the healthcare politics of every single country, because we'll be here forever.
No.
Duncan, let me bring you in, if I may, because we've talked a bit about the EUFOREA publications. I mentioned those just a minute ago. Now, your charity, Fifth Sense, you are focused on supporting people around the world affected by smell and taste disorders. Now, obviously, it's no secret that partial or complete loss of smell is one of the many symptoms of CRSwNP. I do wonder whether it is minimized, I think, that by many peers, actually. And actually, I think it's minimized by physicians a lot of the time. And when you think about smell loss it's in itself, I think a lot of people and the public think, well, that's no big deal, is it? Just having a bit of smell loss. It is a big deal.
Absolutely, absolutely, and this is what we're getting across to people. Smell loss in the context of chronic rhinosinusitis with nasal polyps is one of several symptoms, but it's often the symptom that people complain about the most. One of the challenges that people face is that those around them, whether they're friends, family, healthcare professionals, only think about, okay, you can't smell anymore, but they don't really think about what that might mean for people. Okay, so let's just think about that for a minute. Let's consider the knock-on impact. So all of a sudden you can't smell your partner, your children. Okay, that leads to loss of connection and intimacy. You're unable to appreciate the flavour of food and drink. So that pleasure's taken away, but also that can then have an impact on people's diet and their nutrition, which leads to poorer physical health. Yeah. There's also a safety aspect as well. If you can't smell gas, you can't smell smoke, can't smell spoiled food, that leads to people being more at risk, but it also then has an impact on mental health. So there's this tremendous impact on people's wider health and well-being and also personal safety as well that just isn't thought about.
So that's really interesting. And you mentioned then about smell and taste and enjoying food, for example. If you can't actually enjoy food, then what's the point of eating? And then you rightly say, therefore, you don't eat and therefore you run into problems.
Absolutely. In the context of food and drink, people can potentially go two ways. Some people will eat less, okay, and might lose weight. Some people will gravitate more towards foods that they can still taste, so sugary or salty foods, so things they can still get a basic taste hit from. Whichever way you go, people's nutrition is being affected, and poorer nutrition, okay, then has other health implications. And let's not forget, we're talking about a chronic condition here. So this, over a long period of time, can have impacts in later in life. And there's research that's increasing research coming out demonstrating a link between poor olfaction and frailty in later life.
How interesting. And that's down to, we believe, just not eating enough, not having enough calorific input.
The reasons why are not fully understood yet, but that's potentially a factor.
Interesting. Well, actually, your team at Fifth Sense, I'm just reading about this survey that you carried out about the impact of CRSwNP on smell and taste. You looked at patients with CRSwNP. What did you find?
So this is a survey that we carried out in partnership with the University of East Anglia, paper to be published soon. And we asked patients about their experience of life with CRS, with nasal polyps, and also their experience of interacting with a healthcare profession. 71% of respondents said that their loss of smell was the most debilitating aspect of their condition. Okay, people's satisfaction with the management of their smell and taste issues was lower than their overall sort of satisfaction with their management of the condition more widely. And in terms of other things that came up, echo what Dermot and Wytske have said themselves, the need for general practitioners to give an early referral to a specialist, okay? How beneficial having an informed and understanding specialist who then does their best to treat a patient using the full range of tools that are available to them, but that doesn't often happen.
So is it fair to say your findings were pretty much in line with what EUFOREA has been finding over the years?
Yeah, absolutely. I think what we're seeing and what EUFOREA is seeing are very much aligned.
So when you look at smell loss and you compare patients who have CRSwNP and people who have other conditions, is there a difference?
Broadly, the themes and the impacts are very similar. I mean, I lost my sense of smell 18 years ago through a head injury, and I wouldn't say that my experience is sort of different from people who lose smell as a result of CRS. But one thing that isn't a factor is something called parosmia, so smell distortions, where things smell horrible. That doesn't tend to be a factor with CRS. But otherwise, yeah, very sort of similar themes and similar impacts for people.
Brilliant. Well, brilliantly said. Thank you very much. I think it's time to bring in the patients now, isn't it? But all of you, so the three of you here who are patients, you all have lived experience of this, so I don't really need to tell you anything. You can tell me everything about the condition. Now, I know that all of you, your lives changed with the advent of being treated with a biologic. But let me start with you, Chabha, if I may. Cast your mind back before you started the biologic. What was life like?
Well, it was very difficult, obviously. I think people don't realize how difficult it is to have to live without the sense of smell. Very often what I say is it's like living your life in black and white. This is the feeling that I had. And it's true that with CRSwNP, you have a lot of different issues, being serious congestion and having to be in meetings with your colleagues and having to blow your nose all the time, coughing. So that's really a bad area of the disease. However, the biggest issue, and that's my experience, was really the loss of smell. And it has been said before, not being able to smell your kids is something that if you don't live it, you cannot understand how difficult, how impactful it is, and how much actually smell and emotions and like all your kids' souvenirs and all of this is so much interlinked that it has a tremendous impact on your on your day-to-day life.
For sure. Natascha, would you agree with that? Did you have a similar experience?
Yes, but I feel like I had two lives before biologics. As a child, I didn't have any problems, and my problems started with for my feeling, very severe cold, and then that never stopped again.
Wow.
So, and after my, I also had 3 operations and the loss of smell. But weirdly, I can still taste everything. So they are not, I can't smell anything, but I can still taste. Yeah.
So just talk us through, I mean, just so from your point of view, before biologics, how much did it impact on your life?
A lot, because I had sleeping problems. I had also a lot of coughing problems. So people would look at me, and after the biologic, it goes a lot better.
I'll come back to that.
But there's also more understanding after COVID. That's the only positive thing about that period, because I have some friends who lost their smelling sense for a few months. And obviously they got it back, but now they can understand what.
So that's so interesting. So now you have empathy because more people understand. Yeah, that's really interesting. Daisy, perhaps I can ask you, before the biologic, tell us about your symptoms and the impact it had on your life.
For me, it started as a child. I had a lot of ear infections, and it started with that. Afterwards, I got a lot of headache and pain all over my face. I searched for a few specialists from when I was a child, as a teenager, over years, from one specialist to another. And then after a whole period, I came with one man, and he told me that it was better to make a surgery for my nose. After one surgery, there came another one. And after those years, it became better.
Right.
The symptoms were less, the pain was less, but the ear problems were still there. So it went over a few years.
Right. And so can I just ask you, when this first started, where did you go for information? Because obviously you were desperate to know more.
Yeah.
Where did you look?
The GP told us, give us a lot of advice. And he was always looking for new specialists. And when I came back to him and I said, no, it's not really what I was looking for, then he came with someone else. So that was for us a big help.
Right. Fantastic. Yeah. Natascha, what about you? So when this started for you, you obviously also tried to find information. Did you go to the GP? Did you look online? Where did you go?
I did, but I didn't get a lot of help from the GP, so I played Dr. Google myself.
That's very dangerous.
Yeah, I know. Yeah. And at the end, I demanded to go to a specialist.
Wow. Chabha?
I went straight to the specialist. I went to the ENT. So for me, I have to say that the experience is a bit different because the diagnosis came very early. And I went to the ENT. He made all, the exams and very
So that's really
early.
interesting. So you basically fast-tracked yourself to a specialist and got an early diagnosis. What sort of time period are we talking about?
A couple of months.
Right.
But the congestion was so bad, and the fact that, I lost smell for me was like, oh my God, this is really serious. I need to do something about it. So for me, going to the GP was not even an option. I had to go straight to the person who is a specialist.
And were you able to do that in your country? You didn't have to go via the GP?
Yeah, no.
That makes a big difference. Natascha, or should I say Dr. Google, so what was the length of time it took to be diagnosed?
I think it took me a few years.
Wow. And that was because it took time to get to the specialist?
Yeah. Mm-hmm. I also had asthma attacks and got into a hospital, and a certain doctor got really angry at me because I didn't have any puff medication with me, but I didn't even know I had asthma. So.
All right. So we've gone from like a few months to a few years. What about you, Daisy?
Yeah, as well a few years. Yeah.
For you, how did you finally get that diagnosis? Was it by just keep going, keep trying to get the information?
Yeah.
And who gave you the final diagnosis?
The specialist.
The specialist.
Yeah.
And so, okay, we'll move on then and talk about biologics. let me ask you, when you saw your specialist, who told you that biologics were an option and that they might be useful for you?
The specialist himself.
That's interesting. And what about you, Natascha?
The same specialist.
And Chabha, I assume the specialist because you didn't see anyone else.
Yeah, actually, not my usual specialist because it was so disturbing, this loss of smell for me. I looked for so many ways of recovering that I'm lucky enough that I live in France, work in Luxembourg, so we can benefit from both health systems.
Well, that's helpful.
So I went to see a doctor in Luxembourg, a specialist in Luxembourg, and he's the first one who told me actually about the biologics. But according to the conditions at Luxembourg, I was not allowed to benefit from it. And then I heard about it even more from the association I belong to, anosmi.org. And this is where really I got to learn more about the biologics and the effect it has.
So did you say, right, I want to be on a biologic?
Oh, yeah.
Oh, yeah. And what was the difference when you went on the biologic? What happened?
Oh, it's a life changer, right? I mean, you go like from, as I said before, life black and white to, you know, like back to your life previously. Like it's totally different. It's like a new birth.
And what about smell?
Well, smell is totally back.
How extraordinary.
Yeah. After the first injection, maybe a couple of days after, it gradually came back.
And what did you think at that time?
Well, actually, I was very anxious
I'm sure.
at the beginning because it comes back gradually, but then you always have I think that when you have to deal with anosmia, and especially in the situation of CRSwNP, when you have the opportunity to take, you know, antibiotics and cortisone, so it comes back from time to time. But I was always living with this fear of how long will it be there? How long can I smell? Few days, few weeks? And then with the biologics, it was the same, right? I was so anxious. And at the beginning, when it was starting to come back, I did not tell anyone. I was like, if I tell, maybe it will disappear, so I don't say anything, you know, I just enjoy.
Absolutely. Daisy, I see you're nodding along. What's your story?
Yeah.
So you went on biologics. What happened?
Well, it's the same story with me. The tasting and the smell got back. It took me a few weeks, but after all, I was very happy. And then, yeah, you still stay with the feeling of being afraid that it will disappear again.
How extraordinary. What about you, Natascha?
I'm still in the phase of losing it and getting it back.
So how long have you been on biologics?
Well, I'm trying different biologic. It's the third one that I'm trying now because they're seeing which one is best for me. And I have periods with ups and downs, so sometimes it goes very good and I'm feeling like a normal person and I can smell, and then a few weeks later it's gone. And
so that's a real emotional roller coaster.
Yeah, it
for
is.
you.
Yeah.
How does that make you feel?
Sad. Yeah.
Are you hopeful though that you'll get the right biologic, things will improve?
Yes, because the thing is, I get it back sometimes, so that makes me hopeful that it's not broken or.
Yes.
Yeah.
Good. And Chabha, I know that actually it was so profoundly life-changing for you. You even gave your physician a gift.
Yes. Yeah.
Tell us about that.
So after a few months, after I was on the biologics, I had to go back and see the specialist again. And I thought that, you know, I have to get him to understand what the impact it had on me. So I bought him some macarons.
Oh, did you? Macarons?
Yeah, macaron flowers to tell him, because and thanks to that and thanks to you, I could recover taste. So here you go, some macarons.
How wonderful.
And smell some flowers.
Oh, that's really lovely. What a great story. Well, thank you very much to all of you, three of you. I think you've really explained what it's like, you know, and hopefully with you, Natascha, you will get there. You will get that
I hope
panacea.
so.
I'm sure you will indeed. Well, let's now move on and talk about improving patient and provider communication. Because there seems to have been a shift in the awareness of chronic rhinosinusitis with nasal polyps, and this is proving to be critical in the improvement of coordination of care, as well as helping patients to make informed decisions about their personalised treatment plan. Well, the EUFOREA Patient Advisory Board recently proposed the introduction of a new lay language term that would be used alongside CRSwNP, rather like, say, for example, atopic dermatitis is known as eczema, and in the same way that allergic rhinitis is known as hay fever. So the idea here is that CRSwNP would be known colloquially as nasal polyp syndrome. The reasoning behind this is that patients find it really difficult to explain what is wrong with them to their peers because, well, quite frankly, they don't look unwell. So, I mean, it's a really interesting idea, and I know, Wytske, you're probably going to poo-poo this idea a little bit, but the idea, that's because I know you very well. What do you think about this? The idea that, you know, look, we said this is a colloquial term, it helps people to explain it to their peers. In favour or against?
I don't know yet. The good thing is, well, whatever is more understandable is fine. Huh? So in that sense, CRSwNP is a terrible term.
Terrible.
So we need something better. On the other hand, nasal polyp syndrome brings us back to 50 years ago when we said it was nasal polyps. And I think it's so important to emphasize that it's a problem of the sinuses and not of the nose. The sinuses are much bigger. It's the size of a grapefruit in your head that is inflamed. And if you bring it back to nasal, I think that is not ideal. But, well, so I still have mixed feelings.
Okay, so sitting on the fence. Dermot,
Yeah.
I imagine you won't sit on the fence.
I'd have reservations about using that term. So you mentioned hay fever as a term for allergic rhinitis.
Yeah.
Well, that's doing a lot of people a disservice because many healthcare professionals think that hay fever only occurs in June, May, June, and the rest of the time there's no allergic rhinitis. But there are many different sensitizations to different pollens throughout the year. And so people may have allergic rhinitis seasons depending on how many times they've been sensitized. So it can be an on-off disease. But then there are people with perennial allergic rhinitis, and they have symptoms the whole time, often made worse with seasonal allergic rhinitis on top of it. So it doesn't tell the whole story, it masks the story. And as for polyps, well, with all due respect, the vast majority of patients don't know what a polyp is. And it doesn't mean anything to them. I've got a polyp. What's a polyp? I don't know, it's something at my nose. Well, it doesn't tell the story. To those who have it and have the diagnosis, of course it tells the story. To those who haven't got it, they come with a blocked nose or a facial pain or a loss of smell, and it doesn't tell the story because not everybody will have the whole, 4 symptoms that people have with nasal polyps.
How very interesting. Duncan, your thoughts?
I definitely think that there's a good need for a name change. Whether that's the right term, I'm not sure. It's very interesting listening to Dermot and Wytske's perspectives. But I mean, I've got 2 family members who've got chronic rhinosinusitis. But I think I've told them that based on what their experiences are. They don't really know what they're suffering from, other than going, I'm always bunged up. I've got fluid come down the back of my throat. But what are they able to do about it?
Yeah, that's very interesting, actually. Wytske, I'm really taken by that grapefruit analogy, and I think that's really powerful, actually. Let me ask you, Chabha, what do you think about it? I mean, certainly, I do agree with Duncan that clearly we need something that's easier to use in the public domain. Is this it?
Well, I mean, I have a different point of view, right? I mean, they come with their medical background, which I don't have. So for me, this proposal of a name is really good because it's shorter. And what I like about it is I mean, it's true. It's not in the nose, but it's the sinus. However, when you experience it, everything is happening around your nose, right? You can't breathe. You sometimes you also have asthma with it. But for me, having a short name and having the word syndrome in it is also something important because it reflects the importance and the severity of the disease. So I think for me, I think it's a good name. However, as I said, it's my patient point of view.
That's
I don't have the medical background
but
that
the patient,
goes with it.
but the patient's very important in this. Natascha, where do you stand on this?
I do believe that it has to be a word that everybody can pronounce. And but on the other hand, polyps are not my only problem, so maybe it is a little bit
So
short.
it sort of works, sort of doesn't.
Yeah.
Daisy?
Yeah, I think so too. The polyps aren't either the only problem that I have. It's a lot more. I've got asthma as well, so yeah.
So that's all really very interesting. I want to pick on what you said, actually, if I may, Chabha. You know, the fact is, you like the idea. I want a syndrome because the syndrome's really important. I mean, clearly, nasal polyps, you're right. Lots of people have no idea what a nasal polyp is at all. But obviously, a syndrome, I mean, that's completely different, isn't it? It's a set of signs and symptoms, which obviously you can then spell out, and they're also all interconnected. But I suppose when you have a syndrome and you then have a cause of that syndrome, you then have a disease. So therefore, I suppose the question is whether having that word syndrome, is that really important to you?
Yes.
Right, that was easy. Natascha, is it important to have a syndrome?
Yes, because sometimes it does feel like I'm having a handicap because I lost one of my 5 senses.
Yeah.
And it already brought me in personally in dangerously situations, like cooking bad meat for my children, and which I couldn't smell. And my husband came home and he was like, "What is this smell in the house?" And he opened the oven and I was like,
What, that
"This
you've
is gone rotten," and I didn't know.
really?
Yeah. Mm-hmm.
So the syndrome thing is important to
Yeah.
you as well. Okay, and to you, Daisy?
Yeah, maybe it is, yeah.
So maybe, are we, Wytske, are we halfway there? So I'm still obsessed with your grapefruit. So what about nasal sinus syndrome?
Yeah, for example.
Would that work better for you? You're on the fence still.
Well, I appreciate the syndrome part,
Right.
and now we need something to add to syndrome to make it to make it more than just the nose.
Okay, Dermot.
It's fascinating. Asthma has been known as asthma for a long time. We're now calling it an umbrella disease, a syndrome, a collection of symptoms, and we're looking for the signs. And then we're also looking for different types of asthma. So having a term like the sinonasal syndrome, I think is useful in that it points a person to where the direction of the problem is, the focus of the problem is. But then it's up to the clinician, with the aid of the patient, listening to the story. The story is all important. If you haven't got the story and you jump in too quickly, you're going to make the wrong diagnosis and give the wrong treatment. Listen to the story and try and figure out what's the basic cause of this syndrome.
Yeah.
And then take appropriate action, because it will be different depending on the cause. And people may have additional things along with the syndrome, like depression, which may need other treatment as on top of the treatment of the actual nose. But it may well be that treating the nose gets rid of the depression. So, because physical things can cause depression as well. So I think the idea of syndrome as a collection of symptoms and signs, I think, is a very, very good starting place. I like the word syndrome. It's the word you put before it, which has to be pronounceable and understandable.
Okay. So, Duncan, how does that work for you? So we've all agreed pretty much that you need syndrome in there. What about sinonasal syndrome, if we don't like the word polyp?
I mean...
or do you like the word polyp?
The problem is, right, I'm also thinking about people with chronic rhinosinusitis without nasal polyps, okay? And how do they sort of fit into this as well? So I think it's a really difficult one. It's a really difficult one.
That's not an answer.
No, it's not. It's not. But I also think with things like this that you've got to come up with something and test it out amongst patients and clinicians and get their perspectives as well.
Just very quickly, what do you think? What do you think of that idea? Sinonasal syndrome or nasosinal syndrome or something like that instead of polyps? Or you like the polyps?
No, actually, I don't like the polyps because polyps is the first time I heard polyps from my specialist. I was really scared. I was like, "Oh my God, polyps! That's bad."
Right. Okay. Well, that's really interesting, Natascha.
I like the second one better. Yeah, the nasal.
The nasosinal or sinonasal
Yeah.
syndrome or nasosinal syndrome. And what about you, Daisy?
Yeah, I like the second one as well. I didn't know what the nasal polyps were when my specialist told me the first time. Yeah.
So that's so we have at least some sort of agreement there that the syndrome bit is really important. It's just what the rest of it is. But I think we've made some progress there. Well, let's now move on to talk about what EUFOREA is actually doing for patients and also healthcare providers to improve communication and patient outcomes. So let's come back to you, Wytske, if I may. Obviously, we've heard perspectives from patients, from healthcare physicians like yourself, about the problems with this condition, this syndrome. What's EUFOREA doing about it?
Well, many things, but probably the most important, what is really unique, is the education part, and education from a patient perspective. So helping patients to understand their disease, making pocket guides so that they understand what the syndrome is. Let's use the word syndrome. But also helping them to talk with their GP or specialist, to ask the right questions, to point to where it's really about. If you understand as a patient that depression can be part of the problem, you can explain that to your GP. Say I'm so depressed because of, if you understand that bad smell is awful and what the consequences are, and that you need warnings for fire or for bad food, etc., then I really hope that in that way that the discussions in the room of the physician will be much better.
And what about training doctors?
Well, we trained doctors, of course, for many, many years, and that's a very important part too. And there, what EUFOREA does in a great way, I think, is making it very, very accessible. So master classes that you can view anytime you like on your own computer, not having to go to a congress, but just say, okay, I want to understand something of the disease. What we lack and what is a real need is how to get to all those physicians that are not aware. And that's probably something you can answer, how we can get that better.
Well, of course, GPs have their own educational meetings, often run by, for example, in the UK, run by primary care magazines, the weekly ones that come out, as you have in Holland.
Yeah.
So putting segments into that on chronic rhinosinusitis would be a good start. I think the undergraduate curriculum is already overcrowded. And you hear this all the time. It's, for example, allergy. Most doctors don't get any allergy training as an undergraduate, and yet 25%, 30% of the population suffer from some sort of manifestation of allergic disease. So I mean, it's a major omission out there. So getting it in the undergraduate curriculum is difficult. It's just got on the postgraduate curriculum for general practice in the UK, but there's nothing about ear, nose, and throat on that. So it is raising awareness of that through educational channels. The national primary care colleges should also be a place to approach. Unfortunately, they're often concerned with general political measures and also educational measures about how to run the consultation and stuff like that, rather than looking at specific diseases. So it is very difficult. Patient groups, I think, are quite important. Patient groups so for example, Asthma UK in the UK changed the face of patient care, and they get the politician's ear. And it's raising the profile of how incredibly impactful this disease is on patients is very, very important. And I think the COVID thing is a two-edged sword. Some people say, oh, you've just had COVID in the last 2 years, of course you've got loss of smell, I'm not going to do anything about it, it will come back. So that would be one approach. And the other person will say, okay, so you've got this, what other symptoms do you have, and can I send you to a COVID rehabilitation clinic, or maybe to an ear, nose and throat specialist to see what else might be going on? Because, I mean, we know, for example, in the UK, with severe asthma, people with potentially severe asthma on a lot of medication, 50% of those never get referred to a specialist, never get referred to a specialist. So you can imagine with the profile that asthma has compared to chronic rhinosinusitis in all its guises, the level of referrals is considerably smaller.
So it's really interesting about sort of medical education, also lobbying the political side of that. I think that is actually really important to raise awareness. Let me just, you brought up the pocket guide, Wytske. Let me just ask Chabha here. The pocket guide, useful?
Yes, very useful.
Why?
Because I think that when you go and see either a GP or a specialist, people are not really aware of what questions they need to ask. So I think it's really good to have, some guidance into what you can ask your GP, and your specialist, what you can ask, because sometimes, we go to doctors where, they are the one with the knowledge, right? So you don't always dare asking the right questions or asking questions simply. And also sometimes I think they just don't realize how impactful it is. I mean, like how many times I've seen several doctors and they were underestimating the impact it has. So I think that, it's really good to have such a pocket guide for patients, but also for specialists and...
So is it fair to say that actually the pocket guide empowered you, and in fact you were teaching some of the physicians more because you knew more?
My experience is before the
pocket guide. But if you'd had it, what difference would it have made?
Definitely it would have helped me to ask the right questions from the beginning. Yeah.
And Natascha, what about you?
I would love to have an app on my phone or something, because I see a lot of different specialists, because I also got cardiac problems, probably caused by the steroids I always took. And they gave me medication that worsens my asthma, and that's a problem sometimes. I have the feeling that some doctors don't look at the whole picture, and everybody looks at their specialized things, the nose, the heart, they don't look at my complete picture,
holistic self.
Problem. Holistic.
Wytske, let me just come back to you. I mean, clearly, obviously, the pocket guide I do think is really important. It's the beginning. What about this idea Natascha comes up with about an app? What else is missing? Is that missing? Wytske?
Could be.
Yes.
I also find it hard. You can, in Belgium, you can have a look at your own medical history on the computer, but it's all in medical terms, which I don't understand. For example, I had an examination of my stomach because of the medication I'm using now. It also gives me a lot of problems with exit, and they have sent me a report with which was wrong with my stomach, but I don't understand it, so I have to visit another doctor only to gain the information, what is standing, or, to get a translation from that report.
Wytske, obviously a really good start. The pocket guide's really important. Is that the end of the story?
No, the start of a story. There are many fields where we want to improve. One of the things we're going to do in the next year is to make sure that there is better information on internet, because everybody uses Dr. Google, and we all know that what is found on Dr. Google is usually not so adequate. So even if you look at Wikipedia, what is there on chronic rhinosinusitis half is inadequate. So one of the things we want to do in the next year is make sure that that people can easily find the right information. So the most used entrances into internet should be perfectly right information.
Finally, let's talk about next steps and what we do from here. Now, clearly pulling all of this together is going to be quite a challenging undertaking and one that requires a real partnership to achieve. Well, this year, more than 12 non-profit and industry partners have joined together to support this initiative. So let me start, if I may, actually, Duncan, with you. Why do you believe that partnerships are so important?
It's because through working together, we can change things. And it's absolutely crucial for patient organisations and clinicians to work together on this issue. We've got to improve education and training for healthcare professionals at all levels, and at the same time, we've got to improve patient education. And I think there's a really important aspect of how we can empower patients to be able to give them the tools, knowledge and confidence so they can push their doctors for that referral and say, look, I'm not satisfied with the lack of treatment, or I'm not satisfied with this wait time. I want to be seen by a specialist, and I want to receive the best treatment and care I possibly can.
So that's really interesting, Chabha. So the idea of there being more associations empowering patients, you know the right questions, you can push until you get the answers that you want. That's important.
So, I'm an ambassador at anosme.org, and I think there are two aspects to it, right? So on one hand, I think that there is the support that you get, because for me it was a tremendous help to belong to this association, because the support that you get by talking to people who go through the same pain as you, I think this is super important. People who do understand, not like, people in your family who go like, or friends, yeah, okay, yes. But so this psychological support is very important. But then, yes, all the work that is being done to get access to information. I said before, through the association, I got to learn more about, the biologics, and also the fact that within the association, they really push people to challenge their doctors, right? Not just to take for granted what they say. And actually, it worked for me, because when I went to see my specialist, he didn't want to give me access to the biologics, and I really had to insist until he accepted, to give it to me, because he wanted me to go through another surgery, which I said no. And then eventually he gave me the biologics.
So that's really interesting. That comes back into your point, really, doesn't it, Dermot, about treatment protocols? No, you can't deviate. You have to do exactly what this piece of paper tells me you have to do. And talking about empowerment, also, it works both ways, doesn't it? One of the things that I think is important to talk about, side effects.
Well, one of the big problems with many of the type 2 diseases is the over-reliance on steroids over the years. And we now know that more than 3 courses of oral steroids over the course of a lifetime it predisposes you to developing diabetes, obesity, sleep apnea, muscle weakness. The list just goes on and on and on. And of course, heartburn, acid reflux is one of those things as well. So because of this, there's a new concept of steroid stewardship, which matches up with antibiotic stewardship. Should we be using antibiotics? Should we be using steroids? And that's a useful tool, perhaps, for patients to challenge their doctors and say, is this actually the best treatment for me, given that bacteria are rarely involved in this process? Sometimes they are, but they'll always be accompanied by a high fever. So if there's no fever, there's no need for an antibiotic, by and large. And are steroids really going to benefit me? They're going to give me a temporary relief of symptoms, but they're not a permanent solution. And of course, from the point of view of the payer, looking at the costs of picking up the osteoporosis, for example, the fractured hips, the fractured ribs, the fractured vertebrae over the course of the years, 10 years' time, we need to look at those costs, the cost of the side effects of the medication, when looking at the total cost of administering the drug. Now, I know that biologic medications are expensive, but the way in which people, not just with rhinosinusitis, with asthma, with chronic bowel disease, with rheumatoid disorders who get biologics, the transformation in their lives, the return to economic productivity, the reduction of side effects, is a very powerful argument, which I think needs to be developed much, much further.
I mean, I think we heard that from all of our patient case studies, really, the fact that biologics made such a difference. Just from your point of view, Natascha, where do we go from here? What more do you think needs to be done?
Looking more at the cause of the disease instead of giving a lot of medications for the symptoms. That would be something that I would recommend.
Fine, perfect.
Yeah.
And Daisy, what about you? What more should be done from here? What else do we do from here?
Yeah, for me it's as well heavy to when you look at the total cost, then yeah, that makes a difference. And the biologics are expensive, but yeah.
But they make a difference.
Yeah.
So it's balancing that. It's balancing all of that out, isn't it? And Chabha, obviously, all of you are at very different stages in that journey. I think. What more could we do?
I think, yeah, the work needs to continue on the education of patients. I think this is where we need to continue putting some efforts because even though, you know, these treatments are available in different countries and sometimes not as accessible, but I think that, yeah, it's about educating and also, again, and I'm repeating myself, understanding the impact because when in France, when the treatment was not yet reimbursed by or taken care of by the health care institution, I wrote to the Ministry of Health and I explained why. I mean, if a treatment for people who are blind would exist, it would not be accepted in our society that you can't access a treatment. And not smelling and not tasting is also a handicap. So I think that, you know, it's really important that people understand the impact it has on our lives.
And you make a great point. It's a really important sense, and that comes back beautifully, doesn't it, to what you do, Duncan?
Absolutely. We've got to get the world to recognise that this isn't just a sort of a helpful add-on. This is responsible for so many crucial aspects of our life. It makes such a huge contribution to our health and well-being.
Absolutely. And Wytske, I think final word to you. We've come a long way. I think there's been enormous progress. Where do we go from here?
I think eventually recognition of the disease in all the forms we can do, from press, newspapers, politicians, healthcare payers, patients, and eventually physicians. Recognition of the disease is the step forward because that is where the progression is made. Because of course here we sit with very experienced patients at the end of a long track, but I'm much more worried about the thousands and thousands and thousands of patients that can relatively easy be helped with local steroids and an eventual oral steroid or a surgery. That is the majority of the patients. And a lot of those patients do not get the care they need. And in many of those, the disease is very treatable with not very expensive measures. So if we can help that huge group and that has to be done by getting the disease better known. That would be my major thing I would like to have in the next 5 years.
Fantastic. Thank you very much indeed, Wytske. Well, sadly, that is all we have time for. Thank you very much indeed to all of my panel for taking part. And I really do want to thank all of you for joining us here today for the second annual Global Chronic Rhinosinusitis with Nasal Polyps Awareness Day. I think you'll agree the conversation has not only highlighted just how disruptive CRSwNP is to the everyday lives of patients, like the patients we've seen here today, but also sharing stories and sharing your stories also, I think, really offers real hope to patients around the world who have, until now, suffered in silence. I think it's also really touching, actually, to see how far each of you have come with your own individual stories in being able to resume your lives and also to enjoy many of the small occasions that so many of us take for granted, all of those sensory occasions that you spoke about a little bit earlier. Well, the good news is that CRSwNP is gaining more recognition in both the scientific and the patient communities. And it's through this sort of open, continuous dialogue between all stakeholder groups that patients with chronic rhinosinusitis with nasal polyps will be empowered to seek out accurate information about their condition, as well as find treatment from doctors who have been trained in the latest guidelines so that they can provide optimal care and referral for patients suffering from CRSwNP. And with the strengthened alliances between EUFOREA and its non-profit partners for this event, it's now up to us to continue this dialogue and continue to raise awareness about CRSwNP. Whether this is the implementation of a new term like nasal polyp syndrome or indeed any other, and how we define the term, the translation of guidelines such as the Chronic Rhinosinusitis Pocket Guide, continuing education for healthcare providers, and finally, the development of a comprehensive practical guide for patients to walk them through their patient journey so that we can together achieve optimal outcomes for patients with chronic rhinosinusitis with nasal polyps. Thank you very much indeed for watching, and goodbye.